Good day. I am Dr. Richard Lawhern, PhD. This presentation is for the 47th World Seminar on Women, Health, and Nursing, to be delivered during the plenary session December 13th through 14th. It is based on and documented in an article by the same name published in Volume 7, Issue 5 of Nursing and Primary Care, 2020. We are going in this direction today. I'll speak first to who the audience is and who intended and who the speaker is. Then we'll address some issues in the U.S. Centers for Disease Control Guidelines on prescription of opioids, which are a central question for many medical practices across the world. We'll revisit the guideline process that was used in the update of the CDC guidelines in year 2022, particularly focusing on major failings of the process and the content. There is some evidence of CDC fraud which will be summarized in this presentation. I will focus then on disqualifying guideline flaws and make reference to a number of alternative practice guidelines. We'll summarize the information up to that point, and then I'll spend a little time on a special bonus chart that will help us to understand the real relationships between opioid prescribing in chronic and acute pain versus widely discussed memes in overdose mortality. And then I'll very briefly review the references in this chart, or excuse me, in this presentation. The intended audience here is an international audience of both primary care clinicians and nurses in women's health. As a speaker, I'm a healthcare writer and subject matter expert on U.S. regulation of opioid analgesics as prescribed, and of clinicians who employ them in pain management. I have over 200 papers and articles co-authored or authored in peer-reviewed journals and popular media, and I have 27 years of hands-on engagement with tens of thousands of peer-to-peer contacts with clinicians and patients in social media support groups for people in chronic pain. I am not, however, a clinician or a licensed physician myself. I'm a healthcare writer and data analyst. Let's start with some of the issues in the U.S. CDC opioid guidelines as originally issued in 2016 and then as updated in 2022. Note that the bracketed numbers in this presentation as we go forward are references that are at the end of the presentation itself. The CDC guidelines on prescription of opioids exert a major influence on both the U.S. and international practice of pain medicine. And pain, as we know from multiple publications, is the most frequent symptom that brings patients to a clinician's practice. In the U.S. alone, there are over 100 million people who will deal with chronic or at least significant pain in any given year. The 2016 guidelines, when they were initially published by the CDC, were very immediately problematic. They were very widely interpreted by doctors and hospitals, and by the way, by legal counsel associated with doctors and hospitals, as an inflexible practice standard. And this interpretation was directly responsible for widespread harms to both patients and clinicians. The guidelines reflected and were criticized publicly for anti-opioid biases, very strong recommendations based on weak or misinterpreted research, unacknowledged professional conflicts of interest among the writers, among other factors. And the CDC was forced to publish partial disclaimers to these issues in 2018. They're referenced here in reference 3 and 4. In December 2019, the CDC announced a review and update for the guidelines, and they called for an opioid work group. That's to say, they called for clinicians and others to nominate themselves to an opioid work group whose mission would be to review and comment on the draft updated guidelines as they would be updated, and to report to the Board of Scientific Counselors of the National Center for Injury Prevention and Control, which was the organization within which the guidelines were being revised. Let's take a look now at the guideline update process between 2019 and 2022. Although the guidelines were initially expected to be updated within a year, the process was extended to nearly 3 years. There were major failings of the update process and content that are indeed documented extensively in the paper from which this presentation is derived. The work group itself raised a number of concerns in a report that was generated in July of 20. The concerns that were raised, however, were largely marginalized and ignored. And the CDC proceeded to double down on the previous errors that many had pointed out in several areas. Notably, there was very weak research grounding behind very strong recommendations, and there was a disproportionate issue on risk. The term risk appears over 400 times in the revised document. There was also an inappropriate emphasis on tapering doses to arbitrary thresholds, and specifically to either 50 morphine milligram equivalent daily dose or 90 morphine milligram equivalent daily dose. There was also an inappropriate preference for non-pharmacological therapies, and we'll speak briefly to some of the issues that surround these therapies with regard to the treatment and management of chronic pain. Perhaps the most crushing, fundamental, and fatal flaw in these guidelines is that there was no mention of genetics that moderate opioid metabolism in such a way that there is an estimated 15-to-1 range in minimum effective dose between individuals. The resulting guideline is very fatally flawed, and the errors were known to the guideline writers and reviewers before publication. This is documented extensively in published work. Let's give a little emphasis to some of the disqualifying flaws that are in these documents and that clinicians now working in chronic pain should be aware of. The CDC directs clinicians to perform a risk versus benefits analysis for each individual patient before a decision is made to manage their pain with ongoing opioid therapy. However, the guidelines do not provide a framework for analysis. The consequence of that lack of direction is that clinicians are basically left on their own in an increasingly hostile regulatory environment. And many are leaving practice, at least leaving the practice of pain medicine because of this issue. We also know from multiple sources, and they're noted here, that the incidence of treatment-related addiction or mortality in clinically managed patients is too low to measure reliably. And this comes again from a literature that I'll speak to toward the end of the presentation. We understand as well that demographic risk is dominated by a patient history of clinical depression or substance use disorder. And these are markers for patient despair, but not by previous treatment with opioid analgesics. In one study of the risk factors involved in well over 1 million patients, the risk of a severe negative outcome in clinical treatment of pain examines something like 12 major factors, and of those 12, only one is related to the past history of treatment. The rest are related to a documented record of previous incidents of clinical depression, other behavioral mental health disorders, or of attempted suicide. Likewise, the CDC guidelines, as published in both 2016 and 2022, assert that non-pharmacological therapies and non-opioid pharmacological therapies are preferred to opioids. But there's a fundamental issue in that assertion. First of all, there are no published trials that directly compare opioid therapy to non-pharmacological therapies. There is a landmark paper, it's over 1,000 pages long, issued by the Agency for Healthcare Research and Quality, AHRQ, in the US. And in that document, we discover by careful analysis of the appendices that pain reduction for these non-pharmacological therapies is both marginal and temporary. Of the evidence that has been recovered from medical trials reports is candidly abysmal. Only 218 of 5,000 trials that were identified by the Agency for Healthcare Research and Quality passed a rigorous quality review according to the standards that are applied by HRQ. And the medical evidence was assessed as weak in well over half of those 200. Differently, and from different sources, we also know that non-steroidal anti-inflammatory drugs have their own dangers, particularly at high doses. And these include potentially opioid toxicity from high doses sustained over time, where we have thousands of hospital admissions every year from patients who experience that kind of toxicity. Let's continue this overview of the updated guidelines. First of all, let's look a little bit more in detail at genetics. There's a 25-year literature on genetics of opioid metabolism, specifically focused on several enzymes that are involved in opioid metabolism in the CYP450 series. The existing opioid trials protocols don't address the wide variation in minimum effective dose between individuals because of something that is called polymorphism in the expression of these, in the expression of the CYP450 series. Some patients can thrive on grams per day, not milligrams per day, because they are poor metabolizers of opioids, generally, due to the way that they are broken down in the liver. Other patients can process enough of any long-acting opioid medication in minutes that in a patient with normal metabolism would be enough to knock down a horse, really. So we have hypermetabolizers and poor metabolizers in any population, and unless you measure and do documented laboratory testing for these for the expression of these genetics, you won't know whether any individual patient is actually a hypermetabolizer, a commonly or let's say normal metabolizer, or a poor metabolizer. The consequence of this absence of consideration for genetics in much of the literature is that the trials literature for opioids, and I might add for quite a number of other drugs, essentially needs to be burned to the ground and done over. And as a consequence, it is my view, and that of many practicing clinicians who've studied these issues, that the CDC and the derivative U.S. Department of Veterans Affairs and DOD, that's to say Department of Defense, guidelines, need to be completely repudiated and withdrawn without replacement. Fortunately, there are alternatives to the CDC opioid guidelines that could be used instead. They've existed for quite some time. One that may be broadly familiar to this audience is the World Health Organization Ladder of Pain Management. Originally developed for cancer in 1986, this framework has since been expanded. It is for general treatment of pain using both NSAIDs and opioid. It's widely taught in medical schools. Many will be familiar with it. Likewise, perhaps a little less known, the U.S. Federation of State Medical Boards in 2022 published a guideline that did not include dose limits because it was generally recognized that dose limits are inappropriate for patients who are less sensitive and less able to metabolize opioids. There are in the U.S. and elsewhere, likewise, guidelines of specialty academies and boards, and there are a number of other informative sources that are referenced in the list that you will see at the end of this presentation. Let's summarize. The process of oversight in revising the CDC guidelines in 2019 to 22 was essentially predestined to fail because the CDC had no intention of paying attention to it. A large body of evidence supports prescription of opioid analgesics as both indispensable, safe, and effective with appropriate clinician monitoring in ongoing in-person patient-clinician relationships. However, the guidelines as published by the CDC for both acute and chronic pain are fatally flawed, and it is my position as a data analyst and healthcare writer that these flaws render these documents inappropriate for the guidance of clinical practice, which means for many of you, for most of you. Alternatives to the CDC guidelines do exist. They've been validated over the last 40 years. Now we're going to go to a special bonus chart before we basically briefly review the references. For the last 7 years, I've been working to understand the relationships between opioid prescribing versus overdose mortality that may have involved opioids, among other drugs. And as a consequence, I've been working in a database called the CDC Wonder database, which has in it a very structured search process for data involved in death certificate reports across the United States. There are 2 different databases that are involved there that are quite important. But the CDC has never plotted the data in these 2 databases that I know of against one another. When I bothered to do that, largely out of the work that was published by a business analyst by the name of John Allen Tucker, whom I want to explicitly acknowledge here. When I bothered to take a look at some charts he published in all places on Twitter in 2016 and 17, I saw some charts that look a lot like this one, and let's basically review what this chart has on it. The horizontal axis of this chart is opioid prescriptions per 100 U.S. population on a state-by-state basis. Each of the green points represents one of the U.S. states or the District of Columbia. What the CDC tells us is that in 2016, and to a lesser degree since then, and since basically 1999, because we can see the data all the way that far back, there's a range between roughly 30 prescriptions per prescriptions per state population, and roughly 120. It's a 4-to-1 spread. The number of reports in which opioids are involved in mortality from death certificates per 100,000 population varies from a low of about 8 reports per 100,000 in some states to as high as 50 reports per 100,000 population in a few other states. But when you plot the state-by-state data on a single chart, it resembles the blast of a shotgun against the barn door. There are no trends in this data, and if prescribing was in fact a significant factor in opioid-related overdose deaths, we should see an upward trend line and some grouping of the data points around that trend line that suggests a relationship. And there just isn't any. This chart and others like it that are published on, among other places, the blog of Dr. Lynn Webster, who is a former president of one of the American academies of pain. It demonstrates basically that when you do a comparison of U.S. state-by-state opioid prescribing rates versus mortality in reports per 100,000, there's no consistent relationship. This essentially debunks all of the memes that you will hear commonly in public media and even in some medical sources that suggest that there's some strong relationship between opioid prescribing and mortality. There simply isn't. Now we'll briefly review the references that go with this presentation. The original paper from which the presentation is derived is reference 1. The CDC Guidelines is reference 2. That's to say in the 2022 version, the updated version. Reference 3 is the 2019 publication that basically issued cautions to clinicians about overinterpreting the 2016 guidelines. The report of the opioid the opioid prescribing work group that was the basis for the paper that's referenced for this presentation is shown in reference 6. And we will continue through these. I want to give some emphasis to reference 9. Dr. Oliva and a team processed a very large body of data on opioid dependency, opioid overdose related hospitalizations and deaths, and successful suicide attempts for 2 years. It was basically 2010 and 2011. Well over 1 million reports involved in that. And they developed a predictive model that's called STORM, a stratification tool for opioid risk mitigation. That model is the basis for my earlier assertion that the factors of risk that actually contribute to a likelihood of elevated risk in individual patients are not related to previous treatment. They're related to issues of depression, suicidality, or previous diagnoses of opioid use disorder in some context other than medical. Likewise, several sources, including Bratt and his colleagues in reference 10, address the question, do we see prolonged prescription of opioids in patients that are treated with them for post-surgical pain? And what he found was that the likelihood of protracted prescribing of opioids to patients who've dealt with one of 12 surgeries, very common surgeries, it's much more related to the type of surgery than it is to either dose or duration of dose in the post-surgical treatment of pain. All of these links, by the way, are linked and they're readily available. You should be able to use this presentation to investigate on your own by way of follow-up. Reference 12 is a paper that Dr. Stephen Nadeau and myself published in the journal Practical Pain Management. in 2018, and it looked at the earliest version of the report generated by the Agency for Healthcare Research and Quality, and looked at some of the limitations of that publication. I might add, by way of fair disclosure, that I sit as an invited patient advocate on the editorial board of this journal. Let's go to the last of these reference charts. Here is a way 16 will get you to the Federation of State Medical Boards, Opioid Guidelines. References 17 and 18 are papers and, if you will, guideline outlines that have been used in the continuing education of clinicians who prescribe opioids for something on the order of 20 years. Dr. Schneider is a nationally recognized subject matter expert, and she is board certified in both addiction medicine and pain medicine. And my own work is also referenced here. This is not to, if you will, toot my own horn, but a paper that I put together on how would opioid prescription guidelines read if patients wrote them was published in the National Pain Report, which is a popular journal, a popular publication, not a medical journal. And it was also featured by Pain Week as a reference worth reading by their membership. With that, I will conclude this presentation, but also make known to those who are viewing the presentation that I am available for follow-up. Richard Lawhern, or Red Lawhern, comes up in well over 9,000 searches on Google. My email address is lawhern@hotmail.com, and I am available to discuss the implications of this presentation with anyone who has viewed it or anyone who will find it where we have it linked on a source that I will publish later after the conference itself. Meanwhile, thank you very much for your time. I hope this has been illuminating, and I am available, as I've mentioned, for follow-up to any clinician who wants to discuss the implication. This concludes our presentation.